Well, I think our panel is back with us. Again, I'm Steve Clemons of The Hill. We're having a conversation with Edwin Chapman, specialist internal medicine and addiction medicine, Dr. Tisha Wiley, chief of the services research branch and associate director for justice systems at the National Institute on Drug Abuse, and Mark Parrino, president of the American Association for the Treatment of Opioid Dependence. I sort of feel like we have three gold medalists in this story who've done extraordinary work on opioids. And I want to ask Dr. Chapman, I mean, I think one of the sobering elements of this story is it's getting worse. It's not getting better. And you've been trying to champion a much broader embrace of reaching people where they are, of trying to get new modalities of reaching people in treatment. Can you help us understand what's missing in terms of getting treatment to people and getting them into, essentially conversations with those who provide treatment? What do you think is very important with that?
So we use medication-assisted treatment in an office-based setting, and that medication is buprenorphine. And also, Vivitrol is another or an injectable form of naltrexone. But buprenorphine has been around in this country for about 20 years. And because it's office-based and easier for patients to access with fewer side effects, because it's what we call a partial agonist, we've been trying to expand that modality of treatment in the office. But that requires a lot of support services. There are approximately 104,000 physicians and other practitioners who are certified to treat, but many will not treat because of the complexity of these patients. We need support from the community, and that community support comes in the form of what we call peer navigators or peer counselors, social workers, and of course, because these patients have high incidence of mental health problems, we need that support as well. So what we developed was an integrated model using telehealth, so that once the patient comes in the office, we could actually access those other services remotely without moving the patient. So COVID really opened up the window for telehealth because it was not readily utilized, but out of necessity, telehealth skyrocketed. So we're hoping that treatment modality or that access to care does not go away.
Do you fear that the telehealth as a platform that's expanded, what you've seen as your outreach and your connectivity with those that need support, do you fear that that's going away?
Well, there's a talk among the insurance companies of really winding back that component, and I think that's going to be a huge mistake.
Dr. Wiley, one of the areas you have enormous resources. I was very, very impressed to learn about the size of your organization and the footprint, but I'm also interested in the fact that one of your specialties is looking at justice-connected populations, which was part of my conversation with the members of Congress earlier. Can you tell us, again, in terms of broadening our own aperture of what we need to know about the populations that need better service, better connection, what is the justice-connected population? What does that mean, and what are we not getting right that you're trying to fix?
Great. Thank you for that question, and thanks for the opportunity to be with you. I think the one of the starting points is that the justice population is inextricably linked to what happens in the communities. So you shouldn't have to go to jail to get treatment, but if you do end up in contact with our justice system, you should have access to the best evidence-based care that we have available. So with the work that we're doing in the Justice Community Opioid Innovation Network, which is funded under a program called HEAL, or Helping to End Addiction Long-Term, under the NIH and run through NIDA specifically, we have a lot we're trying to tackle with that program. And I would say there are 4 big picture things that we could think about and that I hope that as we move forward, we'll keep working on. And one is just about the implementation gap. And I know one of the panelists earlier spoke about how we have medications that we've known to be effective for an extremely long time. And we know this stuff works, but we're not getting into practice. So a lot of what our network is trying to do is figure out models to how to make that work, how to get what we know works out into practice. Another key piece is we focus a lot of our attention on what happens when people become incarcerated. And I think that's really important. Is where we focus a lot of our resources. But I think we need to start moving some of our investments more toward the front end of the system and thinking about, again, that point that you shouldn't have to go to jail to get access to care. And so how do we get people care before they're coming through the front door of the justice system? And the third point is that it's just really, that's especially important because the deeper people go into the system, we have lots of evidence that disparities and racial inequities accumulate and get worse the deeper people go into the system. And I just want to acknowledge, finally, as my last point I want to share, a lot of the work we focus on is focused on opioids because we have a toolkit to help that, but stimulants are a big part of the overdose epidemic right now, and so I think we need to get more care to focus on that and understand how we help people even with a less robust toolbox in terms of effective treatments.
Dr. Wiley, I'm going to, you've said it twice, but I'm going to say it a third time. You said that people shouldn't have to go to jail to get care, and I got kind of a shiver down my spine thinking about it because I said, of course, I understand what you're saying about that. And I guess my question to you, because I don't know the terrain as well as you do, how pervasive is it that the community resources aren't there and that people are going to jail or trying to go to jail to get treatment?
So I can't speak to the data on people trying to go to jail to get treatment, but we do know that a lot of people that come into our justice system that have substance use disorders, the first time they get treatment is sometimes when they're coming into contact with the justice system. We know sometimes coming into contact with the justice system interrupts their care, and that's really bad as well. So it is a big, some people are in cycles, relapse is very common in the trajectory of recovery for lots of substance use disorders, but opioid use disorder in particular. And so sometimes jail comes in the middle of people having had an interaction with services and quit using those services and then trying to re-engage. And so, I think too often we catch them in the jails as opposed to making it easier to get access to care in the communities and keeping them in the communities as opposed to using our justice system to manage those issues. Yeah,
unfortunately, that makes a lot of sense to me, what you're saying. But Dr. Parrino, you have been at this, as I understand it from my notes, from 1974. So I imagine you're one of the essentially the godfathers of this set of concerns, this infrastructure of support. And I just want to ask you, what when you've kind of been in this journey for so long, and I imagine you've seen moments of things that have really succeeded in helping to impact those that have needed treatment and support with opioid dependence, and you've seen things that have shoved the wrong direction. We'd just love to take advantage of your experience to understand what do we need to do to move these numbers in a different direction from your long experience.
Well, I think the first issue, from my point of view, and we're going to urge the Biden-Harris administration to adopt this, is really a national education campaign, and a sustained one, which explains to the American public how people get into trouble with using opioids, and with the hope of educating, potentially breaking cycles. And that's the trajectory, as both Dr. Wiley and Dr. Chapman know, begin with the use of analgesics, prescription opioids, and then moves on to heroin, and then unfortunately fentanyl. So that's one issue. And that's not been done before in an effective way. And the reason I mention this is even at the height of an opioid epidemic, there are still communities that do not want treatment centers in their neighborhoods, in their jurisdictions. And there are zoning ordinances that prevent this. So from my point of view, the federal government is not creating barriers to treatment. It's when you look at states, you look at state legislative action. Now, the other issue with what we're doing within the opioid treatment programs, and that's what ATOD represents, is on June 28th, the Drug Enforcement Administration released new regulations with regard to the use of mobile vans. These are vans that can be connected to the opioid treatment programs. This is a way of expanding access to care in rural and other underserved areas of the country. This is a way where the OTP operates a van and it gets out into the community. The secondary use of these vans is something that Dr. Wiley knows all too much about, which is how it gets into the justice system. And we have operating vans that do that right now. So an OTP, opioid treatment program, can work with the state opioid treatment authorities. These are the designated state administrators to work with departments of corrections and bring the van right into the correctional compound. This will increase access to care. Another initiative we're working on is what are called satellite medication units, also affiliated with OTPs. These are bricks and mortar entities that can extend the reach of the OTP into rural and underserved areas. We think these two initiatives will increase access to care. At the present time, we think we have about 600,000+ patients in treatment in the 1,800 OTPs around the country. Our goal is to continue the expansion of that and also provide greater care through these different entities. So I know that we're really in a terrible place in this epidemic, and COVID-19 clearly worsened the problem. And as Dr. Wiley said, we are now dealing with not just more powerful fentanyl, but also methamphetamine. So it really is an opioid stimulant problem. And also, just to be clear and to finish, to say that because so many of our new patient admissions are using fentanyl, whether they know it or not, that's what's showing up in the toxicology profiles. It is more difficult to stabilize the patients pharmacologically. So we are having challenges with that. We have to increase dosages of methadone to the extent that we stabilize the patient clinically. So I think with these initiatives, it is going to be a help in closing the gap because we need all of the components to work together, which is why we support the use of buprenorphine in dated 2000 practices, like Dr. Chapman has and his colleagues throughout the country. And our issue is how do you increase access to care, but do it in a way that doesn't compromise the integrity of care.
Thank you for that. Let me ask you all like a question as a layperson in this subject who is very concerned. But my sense is in most communities that if we scratch beneath the surface in our families and among our neighborhood and our network, if we go to that proactive step, we can find people suffering from various forms of addiction who need support. But most people aren't scratching beneath the surface. And either people are very much into the question of how to help in the community, how to help provide services and support, or how to be part of the solution. But most people are on the other side, which is a kind of proximity near it, but know very little. And so I see in communities that I live in the stigma associated with any involvement, either people see no stigma and they say we need to fix this, or there's a stigma that keeps them away. And so I may be framing it wrong, Dr. Chapman. I know you're in this kind of dealing with everybody, but I'd kind of like to know what are the ways in which the aperture of those people who are concerned and involved in trying to be in this, what have you learned that works in talking to communities that may be pretty far removed or think they're farther removed from this problem than perhaps they really are? So it's the stigma question and how we genuinely get beyond it, not through kumbaya stuff, but actually helping people to realize and open their eyes that this is also affecting them as well. Does that make sense?
It makes a lot of sense. So we've really embarked on an effort to actually go to the community. And of course, in the African American community, when we really want to get messages out, we go to the faith community. And so in the District of Columbia, they actually put out grants to about 40 churches. And we've been using those grants to educate the various congregations using Zoom conferences, and it's been very effective. So we've done a combination of talking about treatment. with the 3 medications that we use. We also talk about the use of naloxone for resuscitation. But we also talk about the role of the community in supporting patients and really doing family counseling and other support services. I actually have a peer support couple that was funded through SAMHSA through the faith community as a pilot demonstration. So we know that works, but now we have to incorporate these services from the community. We need paid community workers to actually bring patients into treatment by whatever means necessary. And we also need the support of the various organizations, community-based organizations, for services like housing, food services, clothing, et cetera. We should leave no one behind. And that includes not having people living on the street or living in shelters. COVID has taught us that housing is like medicine.
Right. Dr. Wiley, I'd love to get your thoughts on the same question.
Yeah, I think that there's an individual level to address. So thinking about the ways that community members hold these stigmatizing attitudes and how do we develop interventions that can help reduce that stigma. We've got some work going on in our J-Coin network on that. Also thinking about people who have a substance use disorder, how we can intervene to help them reduce their own self-stigmatizing attitudes. But I think the bigger thing is the structural level. A lot of the ways that we've designed our treatment system means that people don't get care in the same settings where they get the rest of their medical care. So you have to go to an OTP at specific times to get medication, and that serves to reinforce the stigma. And Mark mentioned earlier issues where that then becomes subject to zoning issues in communities, and people don't want those programs in their neighborhoods. And I think we have to, at a deeper level, rethink the way we've organized our treatment delivery system. Think about how do we bring routine addiction care into these routine settings so that you're not going to the place that immediately identifies you as having a substance use disorder, that you can just go and pick up medication at a pharmacy like everyone else. I think if we, and we are at NIDA funding lots of research to look at some of these different models, but I think the ways we've structured the addiction treatment system as separate and apart from the healthcare system serves to reinforce a lot of that stigma. And I think that requires some rethinking at the society level.
Right. Well, great insights on that. And I'm going to give Dr. Parrino the last word. And I just want to ask you, Dr. Parrino, is there, again, coming back to the fact that you've been at this for so long, is there anything at the federal government level? We have people in the policy space here in Washington that you think, I know that the game changer is, and silver bullets are the wrong frame for this, but I'm interested in, if you were to advise people in the federal policy level, one or two things they most could do to work in this space, what would they be?
Well, I've already mentioned it. I think it's also creating a national education, even public relations campaign, which explains what are these medications that we use to treat this disorder, and how do we treat this disorder. There really is an incredible lack of knowledge in the American public on why this is an important disorder to treat. And I think there are a number of issues to address, even in the justice community. So I think that my recommendation to the federal government is the one I've already spoken about. But even at the local level, as Dr. Chapman indicated, it's very important to educate town hall meetings in the community, neighborhood associations, because you can't just address this nationally. It has to be addressed at a local level, and starting with the community-based organizations. We also have to educate. So it's incumbent upon all of us to do so, and then also the role of the states.
Well, listen, I want to thank the three of you. This is a conversation I don't want to end, actually. I want to continue. You all have such deep reservoirs of experience and knowledge and perspective. Thank you so much for sharing your views. I want to thank Dr. Edwin Chapman, specialist in internal medicine and addiction medicine, Dr. Tisha Wiley, chief of the Services Research Branch and associate director for justice system at the National Institute of Drug Abuse, and Mark Parrino, president of the American Association for Treatment of Opioid Dependence. And I should tell you that Mark Parrino is basically on every global opioid dependence thing out there. So thank the three of you so much for joining us today, sharing your views.
Thank you.
Thank you.